Hey guys, Gary Peterson here, and we are continuing our universal patient assessment with the primary assessment. Now at this point, we have already done our scene size up. We've cleared it and we've made patient contact. On our walk up, we're taking in lots of information at the same time. We're taking in all the elements of the primary assessment. That's going to be A, B, C, D, and E. A for airway, breathing, circulation, disability, and exposure. And as we walk up, we're doing them all at the same time because they're not A, B, C, D, and E. They're A, B, C, D, and E. So clearly, if you identify that your patient is in cardiac arrest, circulation, compressions comes before everything else. Likewise, if it's a trauma patient and your first thing that you notice is an arterial bleed, you're going straight to the bleed. Because if they don't have any blood to move around, doesn't matter what else happens, they're not going to be survivable. But if we're going to apply a very basic systematic way, we can simply go in order of A, B, C, D, and E. Now we're going to show you the way to do it for an unconscious patient. Clearly, if they're conscious, it kind of goes in a little different methodology. But if this patient was completely unconscious and I'm suspecting trauma, then I'm going to approach them and I'm going to take C-spine and airway at the same time. I'm going to pass off my C-spine, and for airway, the only thing I care about is patency. So I need to know if it's patent or compromised. If it's compromised, I'm going to take protective measures to change that. If it's patent, I can move on. They're unconscious, they already meet qualifications for high flow O2 under most circumstances. Moving into breathing, I want to expose if possible, and if it's a multi-system trauma patient, then I am exposing, absolutely. But remember, we're doing one assessment for both trauma and medical. So if I didn't have any indications for trauma, there's no issue, then I didn't need to take C-spine. I can just move straight into airway. So airway, compromised, patent or compromised. Breathing, I just want to know rate and quality. Now when I see rate, all I'm talking about is the extremes of high, low, or normal range. When it comes to quality, I'm referring to, is it too shallow? Is it labored with use of accessory muscles? Is it asymmetrical? That's the quality that I'm looking at. For a trauma patient only, I need to rule out whether or not it's a tension pneumo. So for a trauma patient, I'm going to take my stethoscope real quick, and I'm going to do right here inside the armpits at the apices, I'm going to take present or absent, and I just need to rule out whether or not there's a tension pneumo. If it's a medical patient, I just need rate and quality, and I'm moving forward. Same thing for circulation. I'm checking a radial and a carotid, ideally at the same time. Remember, this is an unconscious patient. And the same thing, I want rate and quality. So rate, super fast, super slow. Quality, I need to know if it's absent here, bounding, whether or not there's a variance between the two, whether it's weak and thready, and it'd be nice to know whether or not, you're checking for like 10 seconds, so you're going to be able to appreciate whether or not it's regular or irregular. I don't need to know any other nuances beyond that. For disability, I'm checking and doing a sternal rub real quick here, and I want to know where they fall on the AVPU scale. For exposure, if I hadn't done so already, I'm exposing them really quick to make sure that I don't have any arterial bleeds, and then I'm keeping them protected from the exposures of extreme hot and extreme cold depending on the environment. For our trauma patients, we're also keeping them warm. So that's our trauma and our medical assessment, with a few tiny little things that have to be modified for trauma, like our C-spine protection and like our lung sounds. Other than that, you're going to do the exact same assessment for a unconscious medical and an unconscious trauma. If they're conscious, we're going to talk about later how you move through that and covering all the same bases. But you need to have a single way to be able to move through it systematically. We always gather all the information simultaneously, but if you're in the process of field training or you're the field trainer, you need to know whether or not your candidate is seeing all the things that you see. And the only way for them to be able to express that, for you to know it, is if they're able to actually verbalize their way through. This gives them a method and a vehicle to verbalize through systematically. So that's our primary assessment. They're all equal, and we move through. From here, we can make an immediate treatment decision. The other thing is, in our primary assessment, in general, if you find a red flag, if you find any issue with any of these things, it equals immediate action. You have to do something about it as you find it. Arterial bleed, we're going to direct pressure, tourniquet, wound packing, XYZ. Compromised airway, we're going to take care of the airway. Compromised circulation, We don't do any immediate action on that other than maybe reposition if they weren't already supine. We're going to take care of that. Disability, we're going to make note of that, and that covers all those items. But it means you have immediate action. It also means, in general, that you have a high priority patient who has earned themselves an immediate movement to the hospital. So we're going to do our secondary assessment en route to the hospital. If you're don't have ALS resources, now is when you should request them or intercept with them. And in general, the patient has earned high flow oxygen or better. So that's your primary assessment, and from here we can move into our secondary assessment.